presentation. So before asking you some questions, I would like to have a comment about for our hospital formulation pharmacy, because we can see that in the strategy of treatment of the many kind of diseases, including vernal conjunctivitis. We need a higher dose, higher concentration of cyclosporine A. The only one that's available in the market now is 0.05%, and I think it's not highly concentrated enough to treat the disease, only for dry eye. So we need much more higher concentration of cyclosporine. And similarly, we need some other form of the drugs that can be used in the hospital environment, and not only in our hospital, but also in our system of the ophthalmic hospitals, such as mitomycin C, thiophanate, and pilocarpine, atropine with a different concentration, and also antibiotics and Avastin. So I think that that poses the importance of the formulation pharmacy in the hospital. And we have many discussions with the pharmacist Ming about this formulation change that need amount of money around 2 billion Vietnam dong. So I think it's very worthy to invest that amount of money, because many patients need that formulated drugs. For example, the cyclosporine with the higher concentration. I have many patients from also from the cornea department had to go abroad, for example, to Singapore, to get consulted for several times before integrated into their system, and after that can get some higher concentration cyclosporine, for example, to 0.1% from Singapore. Or another example is the ointment of ganciclovir. Ganciclovir is 3% is very important to the uveitis, especially the anterior uveitis due to CMV. Very important. And many persons need that, but they need to go to Singapore to get that. So, and many other examples. For example, another example from my department is the mitomycin C, that we need a company to import a kit of mitomycin C that approved by FDA, and that very expensive, about $1,000 for one kit for one patient. So, but with the mitomycin C that can be formulated in the pharmacy or hospital, that can reduce very much the price, only the several 100,000 Vietnam dong only. So I think, in brief, the investment of the chain of the formulation pharmacy in our hospital, I think is very in need, and also for the whole system of ophthalmology in the whole country. So I would like to call over and over again the attention from all the doctors in the hospital, especially the board of directors, that we, the clinicians, think that, and all of us agree that we need that system in our hospital, and we hope that in the future we can pay more attention and invest that formulation of pharmacy in the hospital. And I have some question for you, because I think it's very important, but I think the question now for myself is difficult. You need to write down. The first one is why the pupil in the vernal conjunctivitis is so weak. It's much bigger than the seasonal keratoconjunctivitis. So, what the mechanism, what the pathogenesis that why the papilla is that big size? That's the first question. The second question is, what do you think of the allergy to the weather? So, what is the factor in that weather change can exacerbate or can cause the problem, the allergy problems? You think that the humidity, or you think that the pollen, or rain season, or what is the exact factor that cause a problem? And the third one is, what about the role of the hormone? Because we know that vernal keratoconjunctivitis, for many cases, many children, after the puberty, the hormones change, they grown up. And after the age of 12, the problems all gone in many children. So what are the role of the hormone? So those are my three questions.
Thank you for your comment and question. For the first question, why the pupilla in vernal conjunctivitis is bigger than other form of conjunctivitis, I think it's related to the pathophysiology of vernal keratoconjunctivitis. You can see the keratoconjunctivitis is a T lymphocyte T driven disease. So they have an indirect mechanism to active the immune system. After the T help try to the active, so that we have to have the active of other cell of immune system, and the key of the keys of the pathophysiology of vernal keratoconjunctivitis. That is after the active mast cell, the eosinophil will active, and they get the infiltration of this cell to the conjunctival side, conjunctival tissue, and so it gets the proliferation of the pupilla. So it's bigger than in other form of conjunctivitis. And the two in the second question, the weather is the role of the weather in the onset of vernal keratoconjunctivitis, usually in the spring and summer. In the literature, they don't see clearly antigen of vernal keratoconjunctivitis as other form of allergic conjunctivitis. So they say the regard associated with the warm and hot weather. But I think with this question, I want to ask Dr. Thủy for more comment. The third question, they say on the third question, the vernal conjunctivitis subside after the puberty or adolescence, because in the literature they think the associate between the vernal conjunctivitis with the sex hormone, sex hormone, and I don't get from the article and the document of some research about this, but they see the author, the researcher see the associate between the sex hormone and the hormone, sex hormone, and the associate with the vernal keratoconjunctivitis. I think as
That's okay. I don't get.
No, it's common in male and the female. So, but they can see the vernal conjunctivitis with the adult. if in the case of autosomal conjunctivitis, the role of sex hormone is not important. But before the onset, when at the first decade of life is important. Is more important.
So you mean that for the relationship is with sex hormone. You mean that which increase the concentration in the sex hormone, you can reduce.
Yes, because the gender hormone is associated with the development of system, immune system. Through some complex progress. So maybe I will I will more read and find more document to demonstrate this this.
Okay, just another comment about the size of the papillae. Is due to the face that holds ocular surface remodeling. That's why the papillae are so big. In comparison with the model conjunctivitis with the asthma, that's why that changed the tissue remodeling. It's not only the allergy mechanism. Whether
the second question of Dr. Tấn, I think is outside of the season. All of article and in literature they said that the humidity maybe the pollution can affect the degree of severe disease, but I think in myself and in my experience, I saw that the humidity is affecting more than other factors because I have some patients when they live in north of our country and have so much severe state, and I have even I have some patients with dependent of corticosteroid when they was cheap, but when they move to the north or in center of our country, like Da Nang or Nha Trang, the disease was totally disappeared, and they don't have any treatment after that. So maybe the humidity can affect or not as that affect the severity of disease so much. And about the third question of Professor Tấn, relate on hormone or growth factor, do you mean that? I think maybe that depends on individual observation, because I saw that if the patient have started a disease as early, so the progression is much more severe. That not depend only on the hormone growth factor or something, but on all the literature they already said that the sex hormones like the male we have more popular than female in this disease. But outside of that, I think maybe It depends on the individual. If the patient has disease much more earlier, they have also progression very quickly and more severe.
Dr. Cơ, do you have any comment or question?
Yeah, thank you for your long audio about VKC. As you mentioned, we meet many VKC patients every day in consultation. And in general, in allergic disease and more specific in VKC, we cannot treat the mighty, not curable. We can manage somewhat, but exactly we can control it and make the patient feel more comfortable about that. We cannot kill that. Although you have some new weapon to deal with that, immunomodulator or monoclonal antibody or something like that. And I agree with Dr. Thủy that in some case, very severe, we can send patient, we can change the patient location, change nhau. I advise some patient go to Nha Trang, Đà Lạt, Ho Chi Minh City, and disappear. They become normal person. And concerning the question, I emphasize that the role of exposed too much with UV, right? Very important in mechanism the pathogenesis of VKC, because someone in literature, that's why the patient do not go out from 10 a.m. 2 p.m. with tropical country like try to avoid ultraviolet UV ray exposure or something like that. In hot weather, I learned that children severe or similar like that, if they stay at home with air conditioner, the itching sensation reduce a lot. So I think high temperature or exposure with the sunlight or you avoid very important. And but I think that many prevention solution were very important also being decided with medicine treatment or something like that. The other advice patient have many special instruments in toilet in the try to avoid the pollen or humidity, something like that. And people do not go out in the pollen season or high fever in the overseas. At that time and with the pollen, very important mechanism. And what can I tell for you? I did myself in some case severe. I mean that like a rhino, very big size papillary, and I do the subcutaneous injection, triamcinolone, done very well. And I did some grab of glucose. I try to change the pathologic tissue by normal tissue. Grab of conjunctival glucose. Subconjunctival injection triamcinolone is done very good also. Tachymus, you just recommend. In Europe countries, they did not approve because tachymus is considered like a carcinogen. So tachymus will refill in Europe country, I know, as I know. And I agree with Dr. Tan, we should renovate pharmaceutical department in our hospital, I think. Pharmaceutical department in other hospital, they did many good activity like dilution, they produce themselves many eye drop or drug very good to deal with many disease. I have some one or two person who have toxic like ethambutol. In that case, the patient needs to have cool đầm, dung dịch đầm để uống và zinc solution. I have to send them to the Việt Pháp hospital as they dilute themselves. They pha đồng và bệnh nhân uống là khỏi. Còn viện mắt này không có đồng đâu con. It's okay, crazy. Thank you.
I'd like to ask you if you have a presentation about bronchial conjunctivitis. Do you treatment many patients with bronchial conjunctivitis? Are you using antidote like cyclosporin A and also monoclonal antibody like dupilumab? You already applied for this whole patient, and how was the result in the patient you were treated?
In fact, our department and the start of the presentation, I say about the viral conjunctivitis is common in the clinical office more than the hospital because with the case of mild and moderate, even severe, they can manage the patient outpatient as an outpatient. When in the severe in a severe case, when they go to our department, very is so rare patient have to use monoclonal antibodies, and in the case of use monoclonal antibodies, I send to the Backman hospital with the allergist as an allergist for patient to use medication. And in fact, I know about the using of this medication, monoclonal antibody. So I follow the patient with after systemic treatment with these antibodies. And then in 1 to 2 cases, I have a choice to follow up. I see the result is very good. It reduce the symptom and sign of the patient because in this patient they have with the conventional treatment such as steroid, dual acting, and even cyclosporin is not effective. And with the antibody, I think it's add-on treatment. Very treatment is so effective for the patient. In one case, 1 or 2 cases, in all not
much.
Yes.
Okay. So how about the use of cyclosporin A for the patient? Do you have experience about treatment by cyclosporin A?
Cyclosporin A.
Yes. Or conjunctivitis?
In our hospital, we have only the concentration of 0.05 is hepatitis. But in the new Parism, they use the higher dose.
Yeah, I know.
Yes, but in some cases, they use more at the higher dose. I asked them go out and order from through some pharmacy company to ask for higher dose, such as I can visit certain company. They have a 0.1% cyclosporin A. But in the literature, they can prepare the cyclosporin with higher dose, 0.1 to 2% by using cyclosporin in the injection form for the cancer patient, and they dilute in the artificial tear to have a higher dose of cyclosporin to efficacy patient. But in fact, I use only 0.1% for patient.
Yes, in literature, they often use for 0.1% with cyclosporine, but I used to told that you ask patient go to pharmacy to order this kind of eye drop. So what is this pharmacy I can buy? Because the Dr. he said that he often have to ask the patient go to Singapore to buy it. So in Vietnam, if I get some patient, sometimes I also meet some patient with conjunctivitis, and even some my patient come from Ho Chi Minh City and come here with very severe disease with glaucoma. So I have to treatment by surgery, deep scleral taberectomy. So where you can get is it cyclosporine A with 0.1%. Where can I buy it? You just have to ask the person go to what pharmacy.
Companies from Singapore, so Raffle.
No, in Vietnam.
No.
I see.
Carry on,
I think because the Dr. Jones, he said about in our hospital very need many medication, but the pharmacy cannot get it. So every month we have to ask every department if you need any kind of medication, you put on the name and you ask the pharmacist, and we can ask the pharmacist by in our hospital to use it. For example, you mentioned about the mitomycin C, and I often buy mitomycin C, and because I almost every day I use it. And in mitomycin C is I just buy before about 800,000 Vietnam dong. Now they increase about 1 million Vietnam dong. But it's very easy to get. So you can put the names of the medication, and we will ask bring you guys for our hospital. Okay. Yes.
So the problem is we use it, but inofficially.
No,
we would like to do it. We would like to do it officially.
Yeah, I see. I see.
And another problem is, for example, for fire fit, we can get the bottle of 10 ml. But the law said that you can use that 10 ml bottle for only one patient.
Yes.
It's a waste, a big waste. And also it's a problem with the environment when we throw the bottle away after one patient.
Yes.
So that's why I think that we need the formulation pharmacy or hospital that you can divide into many small vials, small doses.
Yes. Because I think he also makes the small bottle by amplify before.
We need a GMP book criteria for the chain.
I know,
so that's why we need an investment.
Even for Avastin, Vinizumab, now we inject in our hospital every day, but it's available.
For Vinizumab, we have approval from MOH.
Yes.
But we don't have the system that can divide that bottle into the smaller vial.
Yes.
That I think is very important.
Yes.
Please,
I know.
invest that
Very
system.
Because the pharmacy here they cannot make it. Maybe it's a law. So
because he said that we need a change, a technology change that costs you about 2 billion.
yes, even here we can afford for him. But I know about 5 years ago I already asked me